So, good morning, everybody, or good afternoon, wherever you are. Warm welcome to everybody to this session about the very important topic of antimicrobial resistance. And actually, today is a very special day because right now there is a high-level meeting of the United Nations in New York, where member states are talking also about this topic, and hopefully all member states across the globe will once again express and support a commitment to further work on this topic and strengthen their actions. We are here today to celebrate the collaboration on this topic between the Netherlands and Indonesia. So my name is Juliette Severin. I'm a clinical microbiologist at Erasmus MC, and my main topic within this topic of AMR is infection prevention and control. And I'm chairing the session today together with my esteemed colleagues, Professor Mark de Boer and Dr. Frank van Let, and I will just give them briefly the floor to introduce themselves. So please, Professor Mark.
Thank you very much, Juliette. I'm very happy to co-chair this session together with you and Frank. I work, as you said, as a professor in infectious diseases at Leiden University, and I hope we have a wonderful meeting this coming hour. Please, Frank, go ahead.
Yes, thank you, and indeed, welcome to you all. My name is Frank Verlet, and currently I work as an associate professor at the Vrije Universiteit in Amsterdam at the Department of Health Science, and I work mainly in the field of antimicrobial resistance surveillance. And I wish you all a very interesting session.
Thank you. So I will briefly introduce the topic. So I hope that Pakasian and Bu Sabrina can share the slides. Perfect. Thank you very much. So once again, we are the chairs, but I hope that the rest of the coming hour, other speakers will mainly fill the floor and tell about this topic and the collaboration that we have between the two countries. Because I said we have to do this together. We cannot work alone. We have to work together on this topic. So next slide, please. So antimicrobial resistance is often referred to as a slow pandemic. It started already when antibiotics were discovered by the last century, but it's now really accelerating and we have to take action. Next slide, please. In The Lancet, several very interesting publications have been published over the last month with numbers how big the problem is and how big the problem will be in the future. However, it is important to stress that this threat is not evenly distributed across the globe. It is especially a problem in low to middle income countries. For now, in 2019, it was estimated that 7.7 million deaths were associated with bacterial infections, and this will probably rise. Next slide, please. This is again some data for 2019, and as you can see on the map with colors, and you cannot really see the numbers, but where it's red and orange, the problem is especially heavy. Next slide, please. A new forecast was just published this week. This is by a big group of researchers, the Global Research on Antimicrobial Resistance, and they forecasted that in 2025 and 2015, the death rate will increase more and more. Next slide, please. And this is the forecast for 2015, where you see that it's especially a problem in Asia and in South America. So this is where it's red and orange. These are the places that they will probably most deaths due to AMR if we don't take any action. So next slide, please. This is the rundown for today. First of all, the topic will be on surveillance. This will be led by Dr. Frank van Let, and the speakers will be Franciscus Quinteng and Adi Gianli. The second part of this session will be on antifungal resistance, which will be hosted by Professor Mark, and the speaker will be Sam Kleinschuber. And the third session about the One Health approach. The speaker will be Suyu Nyang. And after that, we will have an interactive discussion, and I hope that everyone in the session will participate on that. So I will now give the floor to Dr. Frank.
That I can introduce the first couple of speakers because they're going to share the presentation. It is Dr. Franciscus Quinteng. He's a medical doctor, internal medicine and tropical medicine, and he's currently working in the Adam Malik General Hospital in Medan. And he recently received his PhD at the University of Amsterdam on the role in antimicrobial resistance surveillance and diagnostic accuracy in improving empirical treatment. And he's sharing the presentation with Dr. Adi Sugianli. He is a medical doctor and clinical pathologist. He's currently working in the Hassan Sadikin General Hospital in Bandung. And also he currently recently received his PhD at the same University of Amsterdam on strengthening AMR surveillance in Indonesia. Adi and Franciscus, the floor is yours.
Thank you, Frank. Good afternoon, everyone. So today, I'm Adi and Franciscus will present our findings in the surveillance. So the first one will be the first steps will be read by Franciscus as the presenter of this presentation. Please, Franciscus.
Thank you, moderator and committee, ladies and gentlemen. Good morning. I am Franciscus Ginting. This morning we are talking about antimicrobial resistance surveillance, and new method for rapid antimicrobial resistance surveillance. Next slide, please. Slide, please. Yes, thank you. Talking about antimicrobial resistance. Antimicrobial resistance is global public health, and also related with severe outcome because antimicrobial resistance have negative impact. It's increasing especially in low middle income country, but problem are not only in low and middle income country, but it can happen in the developed country too. When we face the IMR, it can cause of high mortality, increasing loss of stay, and increasing of costing. We can say that IMR is a silent pandemic. There were estimated almost 5 million deaths associated with bacterial IMR in 2019, and mostly coming from sub-Saharan Africa, Southeast Asia, East Asia, and Oceania. Most of the IMR problem or the development is related with inappropriate use of antibiotics, which commonly occur for empirical treatment antibiotics. The evidence of inappropriate use of antibiotic and empirical treatment was during COVID-19 pandemic. We can say that there is increasing antibiotic use in COVID-19, moderate, severe, and critical, although there is not very clear there is bacterial infection or not. And in the COVID area, we can see that there is less monitoring of antibiotic uses. And of course, maybe it can have impact in increasing antibiotic uses, antibiotic resistance in the next. Talking about antimicrobial resistance, for example, in urinary tract infection. Urinary tract infection is one of the most common reasons give antibiotics, and most of them treated by empirical treatment without culture, because a lot of data so that antimicrobial urinary tract infection UTI is mostly moderate and mild symptom. So taking culture, maybe it can take costing and takes time. Evidence of increasing MR in UTI has been shown, particularly for E. coli and Klebsiella pneumonia as the main cause of uropathogen. Some antibiotic options for UTI in many guidelines are cotrimoxazole, fluoroquinolone, ciprofloxacin, and levofloxacin, dedicated for the two pathogen E. coli and Klebsiella pneumonia. In era MR, it is estimated 50,000 until 100,000 attributes death caused due to MR for E. coli and Klebsiella pneumonia because there is increasing of the resistance. Moreover, in the data from GLASS 2022 report that higher data submitted to WHO for UTI. We can see at the beginning 2016, only little countries submitted data for resistance to the E. coli, and after that in 2022, after many countries submitted the data, we can see that the problem MR with the urinary tract infections. Slide, please. The evidence of practice in appropriate use antibiotic is shown with our study in sepsis. Because while sepsis is the fifth biggest cause of death, and inappropriate antibiotics due to empirical use of antibiotics is the most common cause of treatment failure among sepsis patients. Our study in sepsis patients in one tertiary hospital in Indonesia showed there was not adequate in process diagnostic stewardship. Inadequate process diagnostic, it can make overdiagnosed and underdiagnosed. In our data, so there is overdiagnosed and 50% is overdiagnosed. You can make overtreatment. Overtreatment can make MR problem, costing, and mortality. And we can see that from 6 bundle of sepsis, we have to perform microbiology culture. It can happen, so we can have definitive therapy, but actually, in this territory hospital, the performance of water is very low. It is less than 50%. So it's a fact that it is difficult to make antibiotic definitive, and it is difficult to make the escalation for infection of sepsis. Actually, Indonesia has one national guidelines for sepsis. But using that guidelines, in this hospital, they're using guidelines in clinical practice. But the appropriateness of antibiotics was very low. It is less than 5%. It's only 3.4%. Indonesia sepsis guidelines look very similar to Infectious Disease Society of America. Using international guidelines for antibiotic choice is not recommended. Therefore, the following local guidelines is the most appropriate etiology and strategy in this situation. Slide, please. Reflecting to uropathogen, our one systematic review for MR in uropathogen in the Asia Pacific, because in WHO said Asia Pacific is the most high risk, high increasing of MR. You can see the systematic review to the urinary tract infection. We can see here in developed countries, Australia can control MR, but another country, the resistance of MR is very high. It can almost 90%, 30% until 90%. Looking the country reporting, which recently developed or implementation national surveillance system such as Indonesia, India, Bangladesh, we can see that have prevalence of MR compared with other countries. Again, in this evidence, the importance of having surveillance data of MR, it can use to monitor the MR situation as well as providing local guidelines in each country if you use the population-based surveillance. Slide, please. Talking about having surveillance data, we perform multi-center data, population-based, and laboratory population-based in community setting and hospital setting with patients with suspected UTI, sign and symptom UTI regarding of the CDC criteria. the data showed that there was extremely high of IMR. Number one, we can see this. It means there's coming data from the community setting, and number two, data coming from the hospital setting. And the red line said that this is a high level of the IMR. If we want to use antibiotic oral, it is like impossible regarding this data because only nitrofurantoin and fosfomycin were the low resistance. The resistance is lower than 20%. Because clinician in our discussion in Bandung and Medan said only want to use antibiotic if the antibiotic resistance is lower than 20%. Nitrofurantoin we don't have in Indonesia, and fosfomycin is very expensive. In Indonesia, there are guidelines for the use antibiotics for urinary infection and coming from the Association of Urology of Indonesia, where the guidelines still use ciprofloxacin, levofloxacin, and cotrimoxazole. Moreover, the antibiotic guidelines from the Association of Urology Indonesia very similar with antibiotic guidelines from European Association of Urology. So the guidelines in sepsis in Indonesia and guidelines for UTI Indonesia, it takes from the international guidelines. Based on the study, it is very important of having surveillance data that is coming from the local empirical antibiotic guidelines. Slide, please. Slide, please. Yes, thank you. However, although we said that it needs laboratory surveillance, and we need population-based surveillance so we can have the antibiotic guidelines. We try to make data surveillance in Southeast Asia by making scoping review. We observe in 11 countries in Indonesia in period more than 20 years. Sorry. But we can find here there is a very little data surveillance in Southeast Asia. Our finding that because there is very little, how can this country can manage of infection? Because they don't have data, not only population-based surveillance, but also laboratory-based surveillance. You can see here most of the data coming from after 2015. Maybe it is the impact of the WHO when they introduced global action plan, when every country have to national action plan. And we can see there is the data is more than after 2015. But we can see that most of the data, 64%, it is coming from research article. So it means that this is not surveillance because surveillance have to make every year continuously or something because the condition is very, very dynamic. Limited surveillance activities precluding guidelines to empirical treatment therapy, not only laboratory but population-based too. You can see here Malaysia, Thailand, Indonesia has the more activity IMR surveillance, but another country is very, very low. Although Indonesia, Malaysia is very low because this data takes into 20 years old, 20 years period. So they can say that there's need to be increased effort and support because without data, without surveillance, they can very difficult to control the MR, especially for clinicians. So the case strategies included that education, every people, the policy, government has known that the impact of the IMR. IMR is silent pandemic. So every stakeholder have to know about the problem of IMR and try to face that to increasing of IMR. Increasing capacity, the quality of surveillance is very important. And the visible surveillance methodology, like example, Indonesia is very have 1,000 island, more than 15,000, and demography is very it's very different. So it is maybe impossible to make national guidelines because it's very, very different one area, one country to another country. Okay, and it is mean that we need international collaboration. And after that, maybe my colleague Adi will talking about the population-based surveillance and laboratory-based and using threshold surveillance. Please, Adi. Thank you.
So thank you, Franz. So I will continue with that the next slide. The next slide is I'm going to show to all the audience that Francisco already talked about the surveillance, the importance of the surveillance, but what is actually the surveillance and why the surveillance is so important? Surveillance actually is a definition of the act of continuous monitoring of the certain situations. For example, for these cases is the AMR. And by in common, there is a two type of surveillance, like we can see from this slide, is the laboratory-based surveillance, or we call it the passive surveillance, and one is the population-based surveillance, or we call it the active surveillance. The great difference between these two populations is lab-based surveillance is just only giving insight among of the clinical isolates or selected strains that receive in the lab because it's passive. So the clinicians or the specimens are who giving or try to send it to the labs, and then we collected the data based on the identified isolates, which may introduce the name of the selection bias, like we mentioned here in the graph. There is a selection bias in the gray boxes, which means that there might be other patients specimens in the world, for example, or in the community, which is not being submitted to the labs because maybe the clinicians are not aware or the clinicians are not being identified for certain kind of the disease for these populations. So therefore, the main aspect that more likely to have is the population base. The population base is tend to be more likely represented for the data because it started from the population, from the community, or from the patients, and it can give insight of the how the transmission or the resistance can be happening because we know which of the patient or which of the community that we are the data coming from. And the method of using the population base can be derived by two types: is the conventional one and the threshold one. The threshold one that we going to observe and we're going to discuss more clearly in the next slide. Next slide, please. So here for the detail, the difference of the type of the surveillance, like we can see from these slides, the right one, the population base is actually, we call it the conventional population base, is a preferred, actually it's a preferred surveillance. So because it was unbiased, because active searching of the populations, like I mentioned, however, that it needs a lot of effort. One of the most things that we have to consider is it needs lots of the samples, and also we need the time. Time consuming is most the high barriers for the conventional surveillance, and because since that we need certain numbers of the sample, which is can be large, and need the time for to perform the population base, and it difficult to repeat it in the short period. So that's the most barriers for the population base. In the other side, there is a laboratory base, which is very recommended by the WHO until now for the glass surveillance projects. But as I mentioned in the earlier, that it have a potential of having a bias because only a selected because the specimen are depend on the clinicians, and the clinicians might have a different case of the definitions to detect or to assuming that the patient are having an infection or not. So it will be depend on the clinician's decision, and as we know that there might be a different of the understanding about the case definitions belong of each of the clinicians. So that's the bias as comes from. And right, the third one is the threshold survey, or we call it the LCAS. LCAS is stands for the Lot Quality Assurance Sampling. It's like a threshold survey methods, and it can be like mentioned here. There is some advantage, but also there is a disadvantage. But even though that in the LCAS we are not revealing the true numbers of the prevalence estimations, because it's just only give a binary of the options like high or low, but it can provide a rapid assessment of the AMR, which is very, very important in the clinical settings, because the result of the AMR will be show like a high AMR or low AMR instead of the numbers. And I think that we think that the clinicians or in the clinical setting, that must be much more useful instead of the numbers itself. So it can give a lot of information that should be taken into consideration and actions. So next slide, please. So looking at the one of the issue in the laboratory base that I mentioned about the bias, here are the results from our study in the which is published in PLOS ONE several years ago. We in this graph and in this article we show that the effect of the bias will provide an overestimations of the prevalence of the MR, which is very difficult to use the result then for the local guideline recommendation, as already explained by Franciscus in the beginning, which is the empirical guideline should be conducted in the certain different places because there will be a differ of the regulations and it needs a data. But seems that the laboratory-based surveillance, particularly in the outpatient settings or the community setting, is not suitable at all. So therefore, we need another options, another methods to how to perform the better surveillance in the community and also in the hospital. Next slide, please. Yes. So here actually one of our exploration about the threshold survey or for the or we call it the LCAS for the MR. So here the illustration how the LCAS is works well in the MR. So the LCAS actually process is required several components. Like we can see in the graph, there is a population of interest, which is in the first circle with the gray one, and then later we call it the population of interest is called with the name of lot. So the technically is same like being selecting of setting of goodies in the factory in the manufacturing factory. So one of the population we call it of interest we call it lot, and then there is a number of strains that will be good for the need for the assessments, and there's a number of strains which is become the decision rules that will be give you classified into high or low. So in here we can see that in the lot there will be goes with the samples. Samples will be decided on number of strain, which is they might be there. Some of them are sensitive and some of them are will be resistance, and there is some decision rules, high or low, and then all of them will be can say okay, this population will be high or this population will be low. So what is the interpretations? They will be only give two interpretations. So if high, they will be stopping the antibiotics. If low, they will be still give the antibiotics. So this, I think, will be suitable in the for the rapid assessment or the rapid surveillance in the current situation of the MR. Next slide, please. So this is the evidence or the proof that we performed the LCAS in our study. And we use the, there is several definitions like we mentioned here in table 1, but we use the definition of 5 to 20, which is brings us the sample of 44. And we can here we can see in the graph in the right side there we can stratify 11 different or FMR preference or the 11 antibiotics. It also different of antibiotics and the different sites, including inpatient and outpatients. And what is the message from here that the we can see that the black one is should be called indicate the higher resistance and the gray one is the low resistance. And then what we can see here that we can see a different local variation of AMR according to the 11 sites that we perform for the LCAS. So it means that it's very powerful and can be given a different aspect or different perspective of its sites of the AMR. Okay, so next slides, please. So I think this is the final of the comparisons, not comparison, but the final justifications between the conventional and also the threshold. We can see here that both of the conventional and also the threshold surveillance are perfectly estimate the same things. In the population base, we know that, like for example, in the black in the red box, the CPRO and the LIFO are very high of the resistance, and also it's also have in the threshold, which is CPRO and LIFO also the same things. So it means that the LCAS can be also it can be used in the particular of the act as a rapid surveillance for the combating the MR. So next slide, please. So at the end, that we conclude that the AMR is very important and the rapid AMR surveillance is also need to be become one of the things that we have to use in upcoming to eradicate the AMR. LCAS, I think, is one of promising method, and then we can see in the big difference areas such as it's like in Indonesia, which is a lot of barriers, that LCAS might become a primary options for the MR surveillance, and hopefully that it will can be become supporting the data for the national, not just on the local, but also can be used for the national guideline. I think that's it for our presentations for the rapid AMR surveillance. Thank you very much for your for the attention. Back to Frank.
That were really nice presentations. Thank you. So focus worldwide is mainly on antibacterial resistance. But next to this, there's another problem going on, and that's antifungal resistance. And moreover, there are increasing number of persons that are immunocompromised and at risk for these infections. And there are hardly any countries that have a comprehensive surveillance program for fungal infections. And that's something that we cannot ignore anymore. So Sam Kleinstuber, he's a resident in medical microbiology, a doctor, and is now also doing research and his PhD on exploring the possibilities of improving our surveillance of fungal infections, mainly aspergillosis, and of course that will enable also the monitoring of antifungal resistance much better. So without further ado, I'll give the floor to Sam to give his presentation. You're on, Sam.
Thank you, Mark, for the excellent introduction and yeah, nice earlier talk. So not a whole new ball game, antifungal resistance, but there are some key differences. So next slide, please. Today, I'm going to be talking about the FungiSense project, which is a fungal infection surveillance by an artificial intelligence enhanced surveillance program. I'm going to be talking about a bit about that. I'm going to give a quick background in fungal disease and antifungal resistance surveillance, give some background, the current situation about the surveillance, also about antifungal resistance surveillance. Why do we need to do this surveillance? Why don't we have enough yet? And mainly going to talk about clinical data collection tools, which we're going to be using in this project and which maybe could be more widely applicable. Next slide, please. So fungal disease, a quick background. What do people think of when they think of fungal disease? Well, fungal disease actually occurs a surprising lot amount of times. So these are all superficial fungal infections. We have foot infections, nails, usually toenails, skin under the hair, behind the ears, after swimming. Epidemiology varies depending on specific geography, but an estimated 20 to 25% of global population suffers from these kinds of fungal infections. These are almost always benign, though very annoying and sometimes very persistent as well, difficult to treat. Next slide. But what we're mainly interested in is invasive fungal disease. So there are different kinds of invasive fungal diseases, and what we're going to be talking about today is invasive aspergillosis. So invasive aspergillosis refers to illness due to air allergy, airway or lung invasion, or cutaneous infection, or other extrapulmonary dissemination caused by the species of Aspergillosis, a kind of fungus, most commonly Aspergillus fumigatus. So as you can see in the slides, Aspergillus fumigatus typically causes a lung infection, and these fungi are ubiquitous in nature. They're everywhere in the environment, and inhalation of infectious conidia is a frequent event. So why do we not all get sick? Well, because our immune system is extremely effective at fighting off tissue invasion of this fungus. There are a number of important defensive mechanisms, but generally macrophages contribute to conidial clearance and secondary inflammation, leading to neutrophil recruitment to kill the invasive fungus. So these neutrophilic granulocytes are essential to host defense. Well, who do get invasive fungal disease? Every year we have an increasing larger number of patients who have problems with their immune system. For acute invasive aspergillosis, so mostly pulmonary, we have a large hematological group with malignancies. We have people with inborn immunity disorders, but also people that we suppress their immune system with new medication. And this is an increasingly large group, which is important. It can present as a more chronic as well, and then it's usually associated with prior lung damage, so TB or sarcoidosis. And what you see here is an aspergilloma, where actually a large fungal ball just grows inside the lung. Next slide, please. Well, so how often does this occur? We sort of know, but we also don't really know. There was a really nice publication, David Denning in Lancet not too long ago, where he estimated annual global incidence at about 2 million cases of invasive aspergillosis every year, as well as 2 million cases of chronic pulmonary aspergillosis every year. So this is a disease which has a huge mortality rate, huge morbidity rate, and a huge burden of disease on the people that have this. These estimates use a lot of assumptions as well. They're usually based on patients at risk and extrapolate from there. So we really don't know any more granularly than this for global situations. Multiple international organizations and national organizations have advised do more surveillance. Notably, the WHO in 2022 put Aspergillus fumigatus in the top 3 fungal priority pathogens list, due to a large burden of disease and global health, as well as the CDC and the Dutch Health Council specifically talked about fungal resistance in Aspergillus fumigatus and made that a priority, specifically azole resistance. Well, why is this a problem? Because antifungals are used extensively in agriculture, sprayed in the environment, and these are very similar, if not identical, to antifungals we use to treat our patients. And as these fungi are ubiquitous in nature as well as in agriculture, this can be a large problem if we keep spraying these things. So we need to know, how often does this occur? Are there any trends, etc.? So what do we have? Let me give a couple of examples. So next slide, please. In the Netherlands, we have the NetMap, which is, I think, quite famous for its AMR surveillance, antibiotic resistance, but we also have an antifungal resistance part. So it looks specifically at triazole resistance and other clinical Aspergillus fumigatus isolates in 5 participating university hospitals and teaching hospitals. And over the past few years, you can see trends differ quite a lot, and local situations matter a lot as well. And you can see generally differing rates of azole resistance between, say, 3% and over 20%, which is a huge difference and obviously impacts empirical therapy as well. Next slide, please. So we talked about the NetMap. What else kind of surveillance do we do in the Netherlands? Well, there was a nice study of van Grootveld not too long ago, prospective screening in the ICU during a pandemic, during the recent COVID pandemic. From September 2020 to January 2021, 370 ICU patients with COVID were screened to test a screening algorithm with biweekly sputum cultures, and ended up with 52 cases of COVID-associated pulmonary aspergillosis, 14%. We don't have any data on the resistance from there. So stuff like that happens. More internationally, in France, a number of studies have been done. So in 2005, 2007, the SAIF network, they set up a prospective study of hematological malignancies in 12 acute care teaching hospitals in France, a collaboration with the French National Public Health Surveillance Institute, where they identified 430 cases of invasive aspergillosis. And the RESSIF network from 2012 to 2018 was a collaborative effort relying on voluntarily participating university hospitals in France, based on positive lab cultures in hematological patients. And there were 1,500 cases of invasive aspergillosis in the time period, with a global mortality about 34% after a couple of weeks and 43% after 3 months, which lines up nicely what we know from other literature. In all these studies, resistance, antifungal resistance, wasn't really clear, so we clearly have a large gap still missing. Next slide, please. So, what are problems with the kind of surveillance that is done here? Well, as was mentioned in the earlier talk as well, it's not structural. So it doesn't use the same form. They don't use the same methods, which is important for comparison between different kind of surveillance programs, as well as following up trends. When surveillance done, it often uses laboratory cultures as a basis for which patients to include. Well, this is a problem because patients can have an invasive aspergillosis without being culture positive. There are other kinds of diagnostics as well, molecular diagnostics and serological diagnostics, as well as patients can be too ill to undergo the preferred diagnostic methods, which is a bronchoalveolar lavage. And what happens when you survey this and you do want to check, do these patients have an invasive aspergillosis? As I said earlier, fungi are ubiquitous in the environment. So you and I can also inhale these conidia. And if you culture our sputum, they're going to grow on a culture plate. But that does not mean that we have an invasive aspergillosis. So to do this, you also need a lot of extensive, privacy invasive, costly manual chart review, which is quite expensive, costs a lot of time. Recently, we have a nice cohort in 2019 in 2 hospitals of invasive aspergillosis, which cost quite some time. And privacy is also, I think, a very important aspect. That this kind of manual chart review is very privacy invasive, and especially in the Netherlands, I think this is an increasingly relevant discussion where we have more and more strict privacy guidelines and rules. So, next slide. Next slide, please. Okay, so while we're waiting for the next slide, I'd like to talk about why do surveillance? Why is it important to do surveillance? Well, I think recognition of trends in incidence and antifungal resistance, early signaling of new patient groups at risk. I think this is very important. I talked about what kind of new medications and such. In trial registrations, not always enough patients are included to catch rare side effects. So there's always already been some medication where you didn't know beforehand, but as the years go on, you notice, oh yeah, there are more aspergillus infections. So that's important to catch these. We could improve diagnostic and therapeutic algorithms. One slide back, please. Improve diagnostic and therapeutic algorithms. This is important as well because there are some scientific criteria, but not really a consensus of clinical criteria, and there are a lot of different scientific criteria as well for different patient groups. So this is quite complicated. Possibility of specific antifungal interventions are important. So you can use prophylaxis to prevent for high-risk groups and increase awareness for healthcare professionals and patients. Next slide, please. So then we're going to talk about clinical data collection tools, what we're going to be using in this project. CTQ is one such program. So a clinical data collection tool as CTQ uses natural language processing combined with text mining of electronic health records. It connects to 2 large electronic health records, backend as it were. So EPIC and HIGS in the Netherlands, which catches almost all the different hospitals. And how it works is that a hospital has a license with CTQ. It's very privacy-minded, privacy by design, as it were, where CTQ only runs on the hospital's own servers. The data doesn't leave the hospital servers, and you can only log in from the hospital servers as well. Furthermore, all the clinical data is by default pseudonymized and cannot be accessed by people searching CTQ. So all this data is structured. searchable with an intuitive search system where you can combine search terms, specify filters, and fairly easy to extract in a format where you can modify the data. Well, another big advantage of doing it like this is that you could link antifungal resistance, where you can look for both culture resistance and molecular resistance typing, to clinical outcomes, and for example, also search for different risk factors for antifungal resistance. Next slide, please. So how is the fungicide study going to work? Well, the first part, which we're doing right now, is the query development. Fungal disease is quite a complex entity. Criteria are quite complex. So it's an iterative process to really optimize the query. It doesn't have to be perfect because it's surveillance, but we need to catch as many people as we want and be as specific as well. After that, we'll validate the query. We have a number of different cohorts that already exist in two hospitals with which we can do this, in the LUMC and the Radboud UMC. And after that, there will be a feasibility study of a national rollout with a number of participating hospitals. And then hopefully we can implement this as some kind of national surveillance. Next slide, please. So what kind of outcomes are we interested in? Well, primarily to survey, obviously. So it's the sensitivity to detect invasive aspergillosis compared to conventional surveillance. Secondarily, we're also interested in the specificity. So how many found cases have a classifiable fungal disease, the difference in detection between electronic health records, the completeness and flexibility of data extraction. So if some kind of new medication pops up, can we also find this as a risk factor? Or for example, when a pandemic such as COVID comes, which also has a high risk of invasive aspergillosis. A percentage of cases where complete automatic extraction succeeds. How easy is this? Which links nicely with the final point, the time and money necessary for implementation and running this program in a hospital. Obviously, we're all swamped by administrative duties already, so it's important to have a kind of relatively frictionless way to implement this. This, I think, also is where this is really interesting, that we're trying to do this with CTQ to see if this new method is as promising as it seems to implement a kind of semi-automated surveillance. Next slide, please. Well, as a recap, I think fungal disease surveillance as well as antifungal resistance surveillance is an area waiting to be explored. I think that innovative surveillance methods using clinical data collection tools can be beneficial for large-scale data collection, and paradoxically also improve patient privacy, weirdly enough. And if successful, this method, I think, could be applied more widely in other surveillance projects as well, be that fungal surveillance projects or other kind of surveillance projects. Next slide. Finally, I'd like to acknowledge the whole Fungus Sense Consortium, everybody who's collaborating on this, and I'd like to thank you for your attention.
Okay, that was a very inspirational talk, actually. Thank you very much, Dr. Sam and Professor Mark. And this is also a very nice bridge to the next part of this session. You mentioned agriculture as a possible driver of antifungal resistance in Aspergillus, which is a real One Health concept. So this is also the topic of the next part. Because resistant microorganisms, bacteria, but also fungi, they do not respect borders. They do not respect borders regarding countries. This is why we need each other. We need to take actions in all countries in the world, but resistant microorganisms also do not respect borders regarding domains. So we do not only need professionals from the human health domain, but we also do need professionals for other domains, the animal health domain, the environmental domain, the plant health domain, all together. So the next session will focus on the animal health and human health connection. And this is a presentation that will be held by Suyong Yang. He is a PhD student in his third year, if I'm not mistaken. at the University of Utrecht. He's supervised by Professor Jaap Wagenaar and me and Dr. Anus Karunyawati from Indonesia, and Dr. Eldert Zomer, also from Utrecht University. He will give his presentation about one of the projects that he's working on, which is the Coincide project. So please, Suyu, the floor is yours.
Thank you. Good morning, good afternoon. Thank you for Dr. Julia for nice and kind introduction. So I'm very happy and very honored to represent our consortium, Coincide. And in next about 15 minutes, I will tell you what we are doing as a consortium in Indonesia, tackling EMR, particularly on colistin resistant. So if we go to next slide, please. So to give you a background information, as you may know, colistin is the last resort antimicrobial to treat multi-drug resistant gram-negative bacteria. Due to its medical importance, the World Health Organization classified it as the highest prioritized critically important antimicrobial for human medicine. However, this antibiotic has been widely used in food that we eat, the chicken, the pork, pigs, and they use it for disease prevention, growth promotion, and therapeutics. So in order to safeguard the efficacy of colistin, it is quite important that we need to reduce or stop using colistin in animals. So if we go to next slide, we see that the bad news is that colistin is no longer effective in some regions, and I put this in the timeline on the right side. So on the right side, colistin was first discovered from swine bacteria in 1947. In 1980, in human medicine, clinicians stopped using colistin due to side effects associated with neuro and nephrotoxicity. However, in late 2000, there was an interest in colistin again because of this rising increase in gram-negative multi-drug resistant bacteria. And simply before 2015, we understand colistin resistance can occur due to chromosomal mutations. In late 2016, in China, they discovered that there is a new mechanism which is caused by plasmid associated with carrying this mobilized colistin-resistant gene, which is abbreviated as MCR. So when the bacteria carry this plasmid with this MCR, it can just spread further. So that's a big concern for public health and also for human and animal health. So in 2019, the Indonesia government also had the ongoing surveillance system in animal health, and they found detection of colistin in poultry, and that prompted the government to take the great action by banning the use of colistin in livestock. And in 2020, we have established our consortium Coincide to really study whether this ban has any impact on public health and animal health. So if we go to next slide, please. So Coincide is a multi-sectoral transdisciplinary consortium. A few names that Dr. Julia mentioned earlier are in the picture. So just to put Coincide in the who is doing what, I just want to explain a little bit to also highlight the theme of today winter event, which is the collaboration between higher education. So in terms of human health from the Netherlands, Erasmus MC, together with University of Indonesia, UNER in Surabaya, we are taking part of the human sample collections and protocol development. And we have a very unique aspect. So we also included social science and behavior, which is led by Institute of Tropical Medicine in Belgium, Antwerp. In terms of animal, Utrecht University, together with the Ministry of Agriculture, their laboratory, the NGO CFAS play an important role. Also, University of Calgary from Canada, we are tackling the animal health part of this consortium. And we have an external partner, which is the Ministry of Agriculture, and also the Fleming Fund has been really part of our consortium. So next slide, please. And we share one main objective, which is to understand colistin resistance in humans and animals from a policy, behavioral, epidemiological, and molecular perspective. And we can do this study because we use this colistin ban in animals policy as an intervention in 2020. And we use one single indicator organism, in this case, E. coli. And we have a large collection of E. coli before the ban. And that's the reason why we are able to do this study if we go to next slide, please. And to answer this main research question we have, so our main research question in this study is that what is the impact of the colistin ban in livestock on colistin resistance in humans and poultry in Indonesia? In order to understand this question, we need to know the prevalence of colistin resistance in humans, prevalence of colistin resistance in chicken, including broiler and layers, and also to understand the transmission dynamics between chicken and humans. So next slide, please. To answer all these questions, we went to Indonesia and particularly focusing on these 3 districts in Central Java. So you might be wondering now why we only focus on this Central Java and 3 districts. And the answer is quite simple, because before the ban of colistin, we have the previous study where we have a large collection of sample from human and also from chicken. So we want to go back to the same area after the ban and to really see whether there's any differences or not. So next slide, please. So this is what sampling looks like in the community. So we only focus in the community, not in the hospital. So we focus on primary healthcare centers. There's an exclusion criteria. So if anyone experiencing diarrhea and or vomiting, they cannot be included in our study. Indicated otherwise, if they are willing to participate, we collected their rectal swab. We also developed this digital survey capturing risk factor associated with carriage of resistant bacteria. So that includes whether they've been taking antibiotics or not, their dietary pattern, exposure to animals, and even having access to clean water and sanitations. Additionally, we captured this antibiotic prescription exit survey. So anyone involved in our study, if they have been prescribed with antibiotics, we captured this question at the end. And this is quite crucial because it's really important to understand the usage of antibiotics in the community, not only in hospital. So that's the reason why we included this. If you go to next slide. And in terms of layer farm sampling, it's slightly different. We focus on small-scale layer farms in these 3 districts in Central Java. So when we go to the farm, we collected these layer farm management survey, which is also the digital extensive survey capturing information related to biosecurity measures, how they are handling the product, whether they use antibiotics or not. And then we did the boost swab. So if you are not familiar with what the boost swab is, it's a technique, a sampling technique to collect the fecal particles. So basically you put the stereo swab on the boot and you walk around the stable. And then later we use these fecal particles to isolate E. coli. And additionally, I mentioned earlier that we are interested in understanding the transmission dynamics between human and chicken. So we politely ask the farmer to see if they are interested in giving their rectal swab. And at the same time, we collected the same risk factor survey that we capture in the community. Next slide, please. So here are the results. Next slide. So the first result is the ethnography, which is commonly used in social science and anthropology that can identify the blind spot that we cannot capture with quantitative data. And we learned that in this setting, in community and human, also in the layer farms, there is no usage of colistin. However, in these small-scale layer farms, the farmers are using other medically important antimicrobials such as fluoroquinolone, tetracycline, and they even use it for preventive reason. So next. As you see in the picture, in terms of the biosecurity measure, they're not well maintained, it's quite poor. Next. And another thing we did in the fee, and I was also there at the same time. So when someone is collecting the quantitative survey questions, we look around, we basically make the observation. Just to give you an example that when we ask the farmer, hey, do you use antibiotics in food production? They say no. And then, however, when you walk around on the surrounding or look in the crèche, there's evidence of the package of antibiotics. This also reflects that maybe farmers are not aware of what they're using. And also, it was a really good technique to cross-validate the usage data in these settings. And it also reflects that the recording of veterinary medicine and immunizations are not well adequate. And I will give you one case example. If you go to the next slide, please. Next point, please. And then next, one more time. So when we go, this is one of the farms we visited in Indonesia, in Central Java. So when you enter the farm, you simply see that on the left side, that's where the kettles are kept. On the right side, there's a chicken stable, chickens put in the battery cages. we know that these chickens, layer chickens, are treated with antibiotics, and then underneath there's a huge, large pond, a water pond where they keep the catfish. So this chicken excreted their fecal and waste into the catfish pond. Later, these catfish are transported to human consumption. So this also show that it creates a great ecosystem that promote the development and transmission of antibiotic resistance. And I particularly choose this example to show that there's a huge variation in farming practices across small-scale layer farms in these settings, and we see all sort of animals present in the setting. Okay, next slide, please. And now I will talk a little bit about the numbers, epidemiology, and sampling results. So from our field visit to 3 districts in Central Java, Indonesia, we are able to recruit 732 participants at the primary healthcare center. We collected about 710 red swab that later yielded about 674 E. coli isolate. In terms of layer chicken farms, we visited a total of 60 farms, 20 per district. I show you how we did the booth swab, and we did the whole visit in 2 weeks. And based on these farms, we recruited 2 to 3 any farmer or farm worker or their family present in the farm to give the red swab. It is important to note that we isolated 15 E. coli per farm, and we have a total of 60 farms that give a total of 900 E. coli isolate from layer chicken, and we also have about 147 farmer isolate. Next slide, please. Now I will show you the microbiology results. So after we have this large collections of E. coli before and after ban of colistin, we perform phenotypic colistin screening using Chromaga coalesced media spot. So if we go to next 2 times. Yeah. So this is what it looks like. We prepare the Chromaga, coalesced media, and then we use a positive and negative control. In this case, the positive controls are MCR1 producing E. coli. And then just to explain very briefly how we did it. So we prepared the 0.5 McFarlane of bacteria suspension, which is equivalent to 100,000 colony farming unit. We put the swab, put the spot on the plate, incubate overnight, and the next morning we read the result. If you see any growth, even the small colony growth, we call it resistant. It's quite important to note for the audience, if you are the microbiologist, sometimes Chromaga collapse plate can cause false positive. We learned that already. However, we realized that this is highly selective for MCR producing E. coli, which is in interest of our study, and we interpreted any resistant based on growth on the plate for phenotypically. So if you go to the next slide. So this is where we get the prevalence of colistin-resistant phenotypic data from E. coli. So before the pre-ban, we found about 2.1% prevalence compared to 1.9% prevalence in post-ban. In humans in community, in terms of the layer chickens, we find about 2.5% colistin phenotypic resistant compared to 3.2% in post-ban. And then the last one is the layer farmer. Is quite important to note that we're only able to recover 48 E. coli isolate and then before the ban of colistin, and none of them grew on this plate, whereas 5 out of 133 isolate grew on this plate. I put the asterisk on the layer chicken farm, and we are, as we speak, we are doing whole genome sequencing using nanopore technology in Indonesia. And based on our preliminary findings and our understanding is that we only find 1 MCR plasmid from pre-ban in these layer chicken isolate, and we don't find anything in post-ban. That leads to, I think, take-home messages in the next slide. So I started asking the questions with, we are interested in understanding if there's any impact on reducing colistin use on colistin resistant in humans and poultry in Indonesia. Based on what we presented here, we cannot, that's the preliminary findings. We need to do more additional comprehensive analysis combining this behavioral, epidemiological, and molecular to be sure to understand the impact of this restriction on resistance in humans and poultry. So that gives to our first take-home message. If we go to next, we found that phenotypic colistin resistance is quite low in Central Java compared to our neighboring countries such as Bangladesh, Vietnam, even Myanmar. And if we go to next, this take-home message is important because next step is to investigate molecular epidemiology of these colistin-resistant E. coli, and really important to validate what we find in phenotypic findings that I showed earlier. Is it in agreement with genotypic association? And this is what we are trying to validate now. And we will get we are very at the end stage of sequencing data in Indonesia. And the last point take home, if we go next, really is a happy ending of our presentation or our study is that our coincide consortium expand this initial colistin ban in animal production center into a more integrated multi-sectoral One Health intervention. And I want to talk a little bit about challenges and opportunities since we have a few minutes left. So if we go to next slide very quickly. Yeah, and also the next slide. There are just 2 slides left. So, I think this is, as we all experience, being in the field, being in the chicken farm, also working together with people from different setups, that can also be challenging, especially when we are working together in different time zones, different culture. So we did encounter a few problems that I took from my field note. I realized that, Indonesia, some of the laboratory are still facing this limited resources, some in animal laboratory center, there's some communications, also protocol deviation. But the great news is that by working closely together, building this great personal relationship, friendship, we were able to standardize our protocol and also develop the tool that works for Indonesia. Because what we learned is that sometimes what we develop in Netherlands might not be the best solution for the region. So we were able to develop tailor tools and resources for our partner, and that was really helpful. And that also obstacle came with opportunity. So if we go to the next slide. So the great opportunity of our consortium is then that we were able to develop and promote capacity building by strengthening the laboratory, not only in human lab, but also in veterinary and animal lab. And now we are even able to implement whole genome sequencing in the government lab. So I think we talk a lot about sustainability aspect of it. So after we finish the grant, what is the next step? But being able to train all the professionals in Indonesia and also working together with some funding agency as Fleming Fund, I think that really promote the sustainability of our collaboration. So I think if we go to next slide. Yeah, this is like just a bonus. So problem solving is a key. We saw so many problems from the sampling to protocol deviation to even some challenges in the field, such as your driver quit 4 in the morning and we have to keep going. So, but I need to acknowledge that our Indonesian partners are very creative at solving solutions, and we solve all the problem we see, and every day was a surprise when we were there. But that was a really good learning opportunity for all of us, part of our consortium. And with that, in the next slide, I would need to acknowledge everyone who is involved in the study. So if we go to the last slide of my presentation. Okay, I think I'm running out of a little bit time, so I can skip this impact pathway. It's just basically showing how our study can lead to the impact, but I think we can just go straight to the acknowledgement sessions. So next slide, please. Yes, so I think there are so many people involved in this consortium, and I need to start with my promoter, Yap Wagner, who also helped set up the AMR surveillance in animal health in Indonesia, Dr. Elder Zoma, Dr. Julia Severin, who is the chair of this session, Dr. Anis, very important person in Indonesia when it comes to AMR. And really, I think we need to thank all our community members, the government staff, and all the participants who are involved in study. So if you're interested in learning more, you can follow me with the QR code. We are active on social media, Twitter. We have a coincide Twitter as well, or X. So any questions, I'm happy to just send it to me. But otherwise, I give the floor back to the chair. Thank you.
Thank you very much, Suyu, for this last presentation. And I'm really happy about this session that we're going from purely a talk about surveillance to a talk about surveillance and One Health, and then to One Health. Please, if you have any questions, I see already quite some questions in the comment sections. If you have more questions, please put them there. And I think the first question, Dr. Frank, you can take this one together with Dr. Adi and Dr. Franciscus.
Yes, thank you. So that is the question whether or not I hear a lot of echo, but whether or not the ALCAS-based surveillance could be a cost-effective solution. This is indeed something that we have addressed also in Indonesia, and it showed that compared to indeed conventional surveillance, the cost of an ALCAS-based surveillance was significantly lower, and it all has to do with the reduced sample sizes. We really go from a conventional surveillance in the 100 and 150 samples to really sample numbers in the teens and not in the hundreds. It must be said that we used an up and running microbiology laboratory. So we did not include investment costs in new laboratory material, because we did it for urinary tract infections. All material and was there, and the largest cost category was actually laboratory disposables. So yes, cost effective, but within a well-organized setting that was already available. I hope that answers your questions, Tanya.
Yeah, that was the question from Tanya Shikma, if I'm not mistaken. Sally Crombeck also had a question that was just... Can you go? Yeah, this is the question from Sally Crombeck. It's also on the screen now. This is about the second talk. Okay, Mark.
You're muted.
You're muted.
Thank you, Frank. Still muted. I apologize. So just to comment on the sensitivity, we cannot give you the final results yet because we're not there yet. But we happen to find new cases that we didn't pick up by manual surveillance. So that's interesting. And we were able to, in our preliminary explorations, some did, and we were able to find almost all cases we did found by manual chart review. And there was another question on the privacy, and maybe I just, Juliette, if I may just comment on that, because I saw some comments on that as well. So all the data remains in the hospital itself. But the key fact is that if you have validated your program, that you do not need to see the identification data of the patient. And that's very important. So you only extract from the medical file the data that you're needed, and it's kind of anonymous. In the last step, you connect the data of the different hospitals with each other. And by that, you get a completely anonymous surveillance. Okay, next question, I would say.
Thanks, Mark. Just a comment to it, because I think this is, as I already said, really inspirational. What you mentioned in your talks about, not only the antifungal resistance, but also the AI component of your study. I have to say that we have in Indonesia, I think 50% of the hospitals do have an electronic system in their hospital. 50% does not. So for the hospitals do not have that. Of course, this is something that's not possible, but if 50% of the hospitals already have such a thing, this is something that we that you could also think about for the Indonesian setting, actually. And I think AI is going to be in the future very important to help us in human health, but also in other domains, but definitely for us. So this is a real nice exploration of what is possible, and I think the future holds a lot more for us. But maybe you want to respond to that, Mark?
Or maybe Sam, because I can only say it's really exciting. We have AI, we have this huge problem, and let's see how we can bring it together. But maybe also Sam wants to comment because he's doing the hands-on job.
I think I can be short about it, but you're completely right. Yeah, it is a really novel method of doing things, and I think what's cool as well that in this case, for example, the antifungal resistance component really comes with the clinical data as well, which I think is quite cool. But I think this is really widely applicable as well. I saw that there was a question that is it usable for other infectious diseases? And yes, definitely, it's already being used for other infectious diseases, but also, for example, for surgical site infections, there are now exploratory projects.
Yeah, and it's actually what you mentioned. It's an overarching thought that by doing surveillance alone, no matter what type of surveillance, only looking at the isolates and the resistance, well, it looks really nice. You get nice graphs, but you miss a part of the data, and that is about the patients that are affected by the respective microorganism and its resistance. And it can tell you so much more about the impact, the consequences, and maybe which type of populations to target regarding preventive measures. So I think that it's not only about antifungal surveillance, but antifungal resistance surveillance, but it's much more. So we'll see what comes.
And this is actually also something that a lot of surveillance programs are struggling with. You need epi data, you need clinical data to really make sense of the data and to make it useful. I completely agree with that. Yeah, and another problem. Sorry?
Yeah, it was nicely addressed in the other talks as well, that clinical data and ethnographic data, and really more than only whether a microorganism is resistant, yes or no, gives you so much more information that actually the results become actionable as well.
Yes, so we're going to, I think the next question for Suyu from, I think, Gert-Jan van den Boer, I would suggest. Gert-Jan van den Boer asked, what are the key factors that have influenced the success or failure of the colistin ban in Indonesia? Are there any impacts from the cultural and economic practices? So, Suyu.
Great. Thank you very much for the questions. I think there's a long answer to it, but I'm trying to make it short. That's what we are trying to find out now with our study. We are in second year phase, and I think from the epidemiology data, we need more information. I think that's what I highlighted. I think we need to be confident with our data quality, so we cannot just focus only on phenotypic colistin resistance. We need the genomic data. We are waiting for that. But I think it was a good initiative that the government took this action by restricting colistin use, because we found the evidence that is circulating in the animal sector, and they took the initiative. So if the government has not done it, I think we might find new emergence of different resistant mechanisms that can, dominate in the human community. So I think, yes, I think that was a good idea to do it. Definitely, there has been impact from cultural and economic practices, especially in animal sector, because if they cannot use colistin, what is the next alternative? I think that is always important. I have a great discussion with people from Netherlands. For example, in the Netherlands, there is no ban of colistin, but it's highly restricted. But then you need to have a culture, you need to have an EST. But Indonesia does not have resources to do that. So I think we need to, again, to make tailored interventions for Indonesia, including these pharma, to really ask them, what are the driving force of usage of antibiotics? Can they not use them? And I think that's the next step that social scientists are also trying to find out. Again, it's a long answer, but I hope it addressed the question.
Mark, did you want to comment on that?
No, actually, I think it's a beautiful answer. Yeah.
Okay, then I would like to go back to one of the first questions, and I think that was not addressed yet, which is regarding the inappropriate antibiotic treatment. What strategies do you recommend? So that would be for the first speakers. What strategies do you recommend for improving empirical treatment accuracy, especially in lower resource settings like Indonesia?
Adi Franciscus, I think that you can answer this question.
Okay, thank you, Frank. So I think that this is the first the questions from the first one. So far, actually, I'm not saying that the
Sorry, you're muted.
Yeah, sorry. So thank you, Frank, for the question. So actually, that the surveillance that had been done in Indonesia is not totally incorrect. But so we still can be used some of the the surveillance that we have in particular in our routine setting, like laboratory based surveillance. Actually, is still powerful for inpatient situations. So, but the problem is sometimes we need a surveillance for the community, which is also need a lot of effort to make a conventional one. So at this moment, that I think that for answering the questions, the first the LCAS is LCAS. I think is the options at this moment, and I already addressed by Frank in the beginning that it already being measured for the cost and everything, and I think that it will be very useful to help the situation, particularly like in Indonesia, which is very having a different kind of the concentrate, and also in the different resources setting in every place in the Indonesia. So I think that's my suggestions for the questions. Thank you very much.
Dr. Frank, you want to comment on it as well? Please unmute yourself.
Yes. So I was pointing out people were muted and I was muted myself. Apologies. So to add to that, the fact that such a threshold survey has such a small sample size, you can actually put it in the different locations at the same site. So actually every health facility has some kind of its own antimicrobial resistance surveillance, and therefore it really informs that population that is visiting that health facility. That makes it a very powerful tool to actually adjust your local empirical treatment if needed. Thank you.
Okay, so I think we addressed all the questions in the chat. Very much thanks to the whole audience for all these very interesting questions. To wrap up, I think we had a very nice session on this very important topic of antimicrobial resistance. We have to take actions across all countries, across all domains. And I think in this session, it became very clear that surveillance is important but challenging, and new ways of surveillance should be explored, with really connecting data from the lab to the epi data and the clinical data to make it really useful data to target our actions. And lastly, but not least, I think in the last presentation from Suyu, how challenging it sometimes it can be to do these studies in a country like Indonesia. We are the three chairs of this session are from the Netherlands. We're very lucky with a lot of electronic systems and a lot of good diagnostics. And this is different, of course, in other settings, just like in Indonesia. So these challenges are something that need to be addressed, and hopefully we can inspire each other and help each other to really make sure that antibiotic resistance does not reach those numbers that I showed in the beginning of the presentation. Last but not least, I think it's November 24 to 26. It is the World Antibiotic Awareness Week. In this week, there will be much more webinars and other events on the topic of antimicrobial resistance. But I think the winner and WHO are also going to organize a session in that week, especially focused on antimicrobial resistance. So we hope that we can continue all these discussions and these ideas then in November, and we will see each other there. And as a final remark, there is going to be I think a QR code at the end of this session, and you can put your feedback in a questionnaire. So please do so, and you can also get a certificate. With that, I would really like to thank all the speakers and my co-chairs, Dr. Frank and Professor Mark, and of course the organizing team in the background, Sasa and Hasian. Okay, thank you very much and have a lovely day. Bye.
Bye-bye.